Thank you so much for joining us for this webinar today, presented by the American Addiction Treatment Association in collaboration with Nelson Hardiman. Our topic today, as part of our series on regulatory compliance issues relevant to addiction treatment programs, is recent regulatory history of addiction treatment, lessons and a look to the future. Where have we been? Where do we go from here? In this presentation, we'll be discussing recent historical issues around addiction treatment and lessons that we can take away from them with respect to regulatory oversight and the future of the industry. As an initial matter, please note that the information we'll discuss today is intended to provide a general guide to these issues discussed. Although we may address issues in general terms, it's important to take note of specific laws and regulations in your jurisdiction that may be distinctive. The information discussed on this webinar is not intended to provide legal advice and should not be relied upon as such. Listening to or watching this video does not create an attorney-client relationship with our law firm, and we recommend, as always, that you seek knowledgeable legal counsel to take account of the laws in your jurisdiction before acting on the information in this presentation. Now, as we get started, I wanted to say a couple words about what we're doing today. The goal of this program is a little bit more on a policy level than some of the other webinars that we've provided. Essentially, addiction treatment is in the midst of a period of major transformation. And while we often attribute the changes to significant points like the availability of insurance reimbursement through the Affordable Care Act and the prohibition on discrimination against behavioral health and addiction treatment as a result of the Mental Health Parity and Addiction Equity Act, the reality is that those two laws, which we frequently cite, are really only a small part of a much larger story of major change in addiction treatment over the past 150 years. Even using that framework is arbitrary. The goal of this webinar is to provide a little bit of a framework of key historical developments, both in the treatment of addiction and in federal and state regulation, with apologies to people who are outside California, which we use for purposes of analyzing state regulation. The goal is to analyze and take away lessons that can help us understand some of the themes that have predominated, as well as a sense of how we got to where we are with regard to many of the unusual facets of how the addiction treatment landscape is regulated, and more importantly, lessons that we can take away about the ongoing changes and what the industry is likely to look like in the future. With that preface, let's get started. I included a famous quote here that's not often used to talk about addiction treatment by George Santayana, saying, "Those who cannot remember the past are condemned to repeat it." It is I use that facetiously, but only to say that there really are many aspects that we're going to cover in the presentation today that we'll see are really recurrent themes, and while they may appear to be new to many people who don't have a historical perspective on addiction treatment, we're going to find, I believe, many themes that run from the very recent history of addiction. I should say, in addition to the caveat that we are going to focus heavily on California from a state regulatory perspective, I apologize for the limitations of this presentation being done by me as a lawyer as opposed to by a historian who could do a fuller job. And I want to say up front that we're going to be fairly selective about choosing historical events to include. I wanted to say a word about what we talk about when we talk about addiction, because the very term addiction, as well as other terms that we're not going to discuss today, like behavioral health, are themselves entitled to some significant historical evaluation. When we talk about addiction, we're talking about a pattern of both substance use and abuse, as well as other behaviors, where the use moves to abuse and then to dependence. As a historical note, I thought that it was interesting to take a look at where the word addict comes from. And the word actually comes from the Roman law, where an addict was a person who, an addictus was a person who was enslaved to repay debts. And the concept of enslavement to addiction is clearly a historical idea that predates any modern understanding of the science behind it. Thanks to the American Society of Addiction Medicine and many other science and clinical organizations, we have a much greater understanding today, which is continuing to evolve, of addiction. And I thought it was useful to take the modern understanding, which is not just a sense of enslavement, but addiction as a primary and chronic disease of brain involving reward, motivation, and memory circuitry in the brain that manifests biologically, psychologically, and in terms of social and spiritual dysfunction, and leading people to pursue the subject of their addiction pathologically in search of relief or reward, with the unfortunate consequence of impairment of their own behavioral control, diminished recognition of significant problems with behaviors that affect their personal relationships, that affect their ability to function, to work, and to engage in other aspects of human life, and their emotional response. And the recognition that addiction is a chronic a disease that has a significant risk of being a chronic problem of relapse and remission, and a progressive one from the standpoint that if untreated or not engaged, can risking the potential of death and disability. So with that in mind, let's go back to what I'm describing as really the early history of addiction. If you look at addiction before the 19th century, a couple of points stand out. One is that the history of addiction as a human health problem is evident in ancient texts across multiple societies. Addictive substances have been a problem throughout the course of human history. Another key point that stands out is that addiction in the prior to the 19th century was overwhelmingly seen as a kind of moral failing or a sin, and it's only in the 19th century that we see the awakening of addiction as a medical condition, as a health condition that's treatable, and it's really only in recent years that we see this advance. And what's significant here is that that stands in contrast to many other classic medical problems, which were not attributed to have an element of sin or moral failing. There are some interesting comments that we're not going to really address in this webinar, but about the extent to which addiction as a problem grew as a result of European colonial expansion, engagement with China, which had a crisis of opium addiction that became a global problem and is in many ways some of the earliest opioid addiction throughout the world, the role of the Industrial Revolution and international trade. But there's a lot to be said about addiction history in this period. And the broad point was that before the 19th century, we see no examples of treatment or engagement that we in the modern period would recognize. Instead, what we see is really a focus on the need for people to exercise personal willpower. I do want to credit a significant source in preparing this webinar was William White's Slaying the Dragon, an excellent history of addiction treatment, and want to commend people and recommend that to the book and encourage people to review the book as well as the resources of William White, which I have included at the very bottom of this slide. So turning to the 19th century, we see the beginning of a recognition of addiction as a medical disease, and the person who's often credited with pioneering the therapeutic approach to alcoholism in particular, which had broadens to addiction more broadly in after his time in the 20th century, is Dr. Benjamin Rush, one of the founders of the country, who's often colloquially referred to as the father of American psychiatry. So Dr. Rush was a significant figure in the 1800s who took an approach to alcoholism as a medical condition, and also was very well known for establishing some of the earliest examples of what we would call sober homes, sober living facilities. Significantly, the 19th century was marked by the use of asyla, the very first alcohol-specific asyla being opened in New York, at New York State Inebriate Asylum. Inebriate was a prior term to before addiction for the same condition. This was really credited as being the first treatment center in the U.S. Treating not only alcohol but opium, morphine, cocaine, and other drugs. And really, the asyla was a 19th century model of treatment. what's significant to see here is that we're, again, in contrast to physician care and hospital care, which has a much earlier point in time, we're really beginning relatively late, really only in the last 160 years that do we see any facilities arising for the treatment of addiction. Also interesting to note, because addiction is a space that has seen a range of public and private resources, that by the 1880s you had the first American, what I would call brand in addiction treatment, which was Dr. Leslie Keeley's Keeley Institutes, and there were over 120 of these in the late 19th century as franchises for addiction treatment. And the last point that I would just highlight from, in terms of thinking about addiction coming into the 20th century, was the extent to which the treatment of addiction was so badly understood in this period that many leading authorities, including Sigmund Freud, believed that the way to treat addiction was by replacing one addiction with another addiction. So, for example, Sigmund Freud recommended the treatment of heroin addiction by giving the addicted person cocaine. And I put up here Coca-Cola, which was only one of many products that used cocaine and other addictive substances as both a refreshment and in many cases as a treatment for addicts. That essentially the way to treat an addiction was with a different substance, something that still does continue to some extent, as we'll talk about in this and in subsequent presentations, in some of the examples of medication-assisted therapies and the replacement of heroin with methadone and other buprenorphine and other more benign addictions. But anyway, that's essentially a snapshot of some interesting things about the 1800s. One thing to notice on this slide is that there are no references to any regulatory agencies in the 1800s because none existed. The regulatory agencies are really creations of the 20th century, as we're going to see on the slides ahead. So we come into the early 1900s in American addiction treatment. It's interesting to note that as early as the early 1900s, you start to see the closure of some of the asyla, and instead you see a bifurcation between addiction treatment for the poor and working class and addiction treatment for the wealthy. Drunk tanks being, for example, the primary means of treating alcoholics who did not have the resources to afford care, and private sanitaria being treatment for the affluent. The sanitarium being essentially the equivalent of a retreat for an alcoholic to be treated for the addiction. The first significant federal law in the area of addiction was the Harrison Narcotics Tax Act, passed by the federal government in 1914. It was a very significant law. It put the control of narcotics in the hands of physicians, and it raised some questions about what the rights of physicians were in terms of treating addiction. As we noted on the previous slide, there was a pattern in the late 19th century of treating addiction by keeping the addicted person stable with addictive substances, either with a different addictive substance or in some cases by simply making sure that the addict had access to the drugs needed to be stable on the addiction. In 1919, the Supreme Court issued a very significant decision, Webb v. U.S., which basically provided that it was not in good faith for a physician to prescribe narcotics to an addicted person to maintain the addiction. Within a few years of the Supreme Court decision in the Webb case, there were numerous prosecutions of physicians, and that's a first a historical trend that I would say that we see today. Physicians who are prescribing narcotics for addiction treatment and for pain, which leads into addiction in many cases, were very much on the front lines of government enforcement action and risk. And that's something significant that continues today under a different set of treatment issues. But physicians were very much both the front line of prescribing and also the front line of risk in terms of mismanagement of patients. In the problem of alcoholism was so extreme in the United States that the 18th Amendment to the Constitution in 1920 actually prohibited alcohol Under the 18th Amendment and the Volstead Act, which supplemented prohibition and clarified prohibition, the United States had was essentially dry for 13 years. This is not something that's often cited in terms of addiction treatment. It's just interesting to note, again, the moral quality and there was a moral opposition to alcoholism, to alcohol as a threat to public health, and a belief that that regulation could control and prevent the problem of alcohol addiction. 1920s were interesting for the first morphine maintenance clinics for the poor, run in some cases by public health departments and police departments. Many of these were eventually closed under federal pressure, and it would not be until much later, as we'll see, that that methadone clinics were actually developed to as a maintenance program. But this was the really beginning of the age of maintenance programs. The first significant federal agency for handling of narcotics was in the 1920s, the Narcotics Division, which was replaced by a whole series of agencies. In some cases, a renaming of agencies, along with moving authority from department to department. We're going to talk later about the current iteration, which is SAMHSA, the Substance Abuse and Mental Health agency that's part of the Department of Health and Human Services. A significant early American date to note is that Alcoholics Anonymous began as a program in 1935 and saw significant growth in the late 30s and the 40s through growing attention to Alcoholics Anonymous and eventually to the other forms of anonymous programs for narcotics. The one thing that's interesting to note throughout this slide, we're seeing a lot about alcohol because in the early 20th century, the focus was on alcohol predominantly, even though we had problems with opioids, with heroin and opium and other drugs. The focus was first and foremost on alcohol based on the numbers of people affected. Turning a little bit to the mid-1900s, we began to see the National Committee for Education on Alcoholism and other organizations popularizing principles of addiction that we would recognize about addiction as a disease on a personal level and then addiction as a public health crisis on a macro level. They were not called, the 12-step programs were not called 12-step programs till much later. They were at this point called Alcoholics Anonymous, but this was a period of significant growth of the 12-step and social model as a result of Alcoholics Anonymous. So I wanted to now interject and shift gears a little bit to how California as a model, and for people who are listening to this in other states, can think about it. There's going to be a different story for whatever state you're in, but how California came to regulate in the area of healthcare and behavioral health in specific. So in 1961, California adopted the California Health and Welfare Agency. It was one of 8 super agencies. It's a relatively late date in the development of regulatory agencies, and this is the agency that today is has been renamed to the California Health and Human Services Agency, one of only several agencies that are working in the area of addiction treatment. And in this period, the 1960s, we begin to see much more of what we would recognize as the modern addiction treatment era. We begin to see some insurance coverage of alcoholism treatment. We begin to see some tensions between whether treatment should be led by peers, that is, by people in recovery from addiction, as opposed to mental health professionals. In 1967, the American Medical Association acknowledges alcoholism as a disease. And you have in 1970, you have the Hughes Act, as well as federal laws establishing the controlled substances rules that govern and the schedules of controlled substances, with the Schedule 1 controlled substances, things like marijuana and heroin being completely illegal and not accepted for any medical purposes, with descending schedules of drugs that were permitted to be used by physicians, but reviewed with extreme scrutiny for the high risk of abuse, including cocaine as a Schedule 2 controlled substance, and with descending levels of concern about abuse through Schedules 3, 4, and 5. The 1970s are also marked a period of accreditation of addiction treatment facilities for the first time. Again, note that this is much later in time than other kinds of healthcare facilities that had been accredited since the late 1940s. You have in 1972 FDA approval of methadone for heroin treatment, and only in 1973 is the DEA created. This was in the Nixon era, where President Nixon identified drugs as a public enemy, really a predecessor of the war on drugs in the Reagan era. To turn back to how things are evolving in California, in 1978, California for the first time has a specific agency intended to regulate alcohol and drug treatment programs, the California Department of Alcohol and Drug Programs. For people who have been in addiction treatment in California prior to 2013, this was the agency that was regulating from 1978 until 2013. It was an agency that was created when then Governor Brown folded in the Governor's Office of Alcoholism, and the California Department of Health, which I noted earlier, took its Substance Abuse Division and put them together within this Department of Alcohol and Drug Programs. At this point, also in the 1970s, interesting to note that the category of residential care facilities as a distinct category from healthcare facilities like hospitals emerges, and the Department of, in 1978, the same year that the Department of Alcohol and Drug Programs is created, the Department of Social Services is established within the California Health and Welfare Agency. So it's interesting to note that addiction treatment services are going to be provided ultimately by three different agencies: a residential care, a community care facility provision of service, a healthcare like hospital type provision of service, and a specific alcohol and drug provision of service. We're going to have a second webinar on the regulatory categories in California that will spell this out more. But I just wanted to note that a lot of the divisions and the silos that exist today in the regulation of addiction treatment really are a reflection of regulatory structures that were created 40 years ago. And it's interesting to look to the future and think about what the optimal structure may be in the future, and the historical context in which these different agency regulatory schemes came into place. Going back to the major history story, the 1980s and 1990s, the war on drugs, depending on under the Reagan administration, depending on your perspective, either begins or resumes in the middle and late 1980s. A significant point is the rise of managed care in the late 1980s. It leads to significant cuts in insurance coverage. So we talk today about the Affordable Care Act as really initiating this period of growth in the industry by ensuring that health plans provide minimum essential coverage for substance use disorder treatment. It's interesting to note that, as we said on a previous slide, that while insurance originally expanded in the 1960s and 70s, the late 80s were a period of significant cutback on residential addiction treatment, the famous 28-day program in particular. And what that did was drive outpatient programs growth and sober living. So sober living as a significant phenomenon is tied in many ways to the unavailability of insurance coverage for residential addiction treatment in the 1980s. Hand in hand with that, we see in 1988, the Fair Housing Act was amended, and in 1990, the Americans with Disabilities Act was enacted, and both laws included significant protections in housing, and in the case of the ADA, also employment for people in recovery from addiction, by noting that people in recovery from addiction are a protected class of disabled persons. And so these two laws, which are often a bulwark in defending the rights of people, of unrelated people, to live together in residential treatment or in sober living and other forms of extended care and transitional care communities, are really an outgrowth, again, of changes in insurance coverage, leading to new structures and the new demand for certain kinds of housing, leading to legal protections for disability rights when communities were not excited, to say the least, about people in recovery from addiction moving into their neighborhoods. We also see in 1992 the formal creation of the entity that I mentioned earlier, SAMHSA, the Substance Abuse and Mental Health Services Administration, and within SAMHSA, the Center for Substance Abuse Treatment, CSAT. These were, SAMHSA was created as a sub-agency under the U.S. Department of Health and Human Services for the purposes of increasing the availability of effective treatment and recovery services. It was not until 1998 that there was funding of states and community-based groups via some of the block grants that have continued until the present time. So this is, again, really we're beginning to see on a federal level, the framework that we work with on a federal level coming into place. Very important, a significant date as we look at the upcoming presidential election. 1993 was the year where the Clinton health proposal that failed, but that I would argue really it was a model that we see with the Affordable Care Act and Obamacare, proposes a national substance use disorder insurance coverage benefit. So it was very much on the agenda of the reform community and the Democratic proposal for healthcare reform in 1993. It was not for another 17 years that it actually came into effect. And I'm not intending to be political in this presentation. I simply point out that it's interesting to note that it was really nearly a 20-year delay on a proposal that was out there, and that as much as we think of the Affordable Care Act as being something new, it was really ultimately a manifestation of an idea that had been out there for a much longer time. I also think a significant date in the 90s to pay attention to is that the FDA approval of naltrexone, which has become an increasingly significant part of addiction treatment, increasingly used in medication-assisted treatment, something we're also going to talk about on the next webinar relating to the various kinds of regulatory issues around different kinds of addiction treatment. Very significant. Naltrexone has been on the horizon for over 20 years and is really significantly accelerating in its prominence, and something that I believe we're going to see much more of in the years ahead. Okay, we want to get to some fairly recent history. Many people talk about the 2000 Drug Addiction Treatment Act data. This was a significant law that permitted physicians to receive a waiver from the DEA based on their qualifications to treat opioid addiction with FDA-approved Schedule 3, 4, and 5 narcotic medications. This was really the law that enabled buprenorphine as a medication replacement. The methadone as a Schedule 2 controlled substance, so it wasn't affected by data by the Drug Addiction Treatment Act. But this was a significant rule insofar as it allowed the medication replacement model to move beyond the methadone clinic, if you will, to physician offices and to outpatient physician treatment, a model that we see proliferating today. Back to California, we're trying to do this in chronological order, and I apologize for jumping from federal to state to broad changes in addiction. The modern, for people who, I include this slide because many people are not clear on how we got where we are in terms of California's current regulatory structure. Until 2007, we had a unified agency, the California Department of Health Services. In 2007, it was divided into two distinct categories, the Department of Healthcare Services, DHCS, and the California Department of Public Health. Now, the California Department of Public Health became the licensing entity for hospitals, including chemical dependency recovery hospitals, laboratories, home health agencies, hospices, congregate living health facilities, which again, if you want to hear more about chemical dependency recovery hospitals and congregate living facilities, I encourage you to listen to our next webinar. But the interesting thing is the Department of Healthcare Services. In 2007, when the Department of Healthcare Services was split off, it was seen as being a distinctive agency that would only regulate the Medi-Cal program. At the time, the Medi-Cal program included the drug Medi-Cal delivery system for Medicaid beneficiaries receiving drug and alcohol services primarily on an outpatient basis, but there was no licensing feature. And what's interesting to note is that as of 2013, Department of Healthcare Services has become in California the licensing entity for California drug and alcohol programs. And we're going to talk on our next webinar about how distinctive this is, particularly when you have two other entities in California, the California Department of Public Health and the California Department of Social Services, that were engaging in licensing activities. We don't really need to talk about why, but the important thing to note is that as of 2013, California no longer has a Department of Alcohol and Drug Programs. All of its responsibilities are transferred to the Department of Healthcare Services, and as of 2013, the Department of Healthcare Services SUD, that is Substance Use Disorder Compliance Division, has taken over the licensing, certifying, monitoring, and complaint investigation for narcotic treatment programs. Narcotic treatment programs are methadone programs, and as well as for outpatient and residential drug and alcohol treatment programs. And it also is the agency that provides certification for counselors as well. So this is a significant development that really takes us to where things stand today in California. And one of the questions is whether this structure will continue or whether there will be significant changes ahead on a regulatory front. To go back to some significant changes in laws, and we're going to take these in reverse order. The most recent significant change at the federal level was the enactment this year of Cara, the Comprehensive Addiction and Recovery Act. Cara is a very significant act. It received bipartisan support, including significant new funding for addiction prevention, treatment, and recovery, support for evidence-based programs, and we're going to talk about evidence-based programs more on our next webinar, and the move towards evidence-based treatment, significant new support for prescription drug monitoring programs, PDMP, that allow states to track prescribing activity and dispensing activity around controlled substances, extensive new prevention efforts, community-based recovery support efforts, expanded availability of naloxone, Narcan is the brand name, to law enforcement agencies to help first responders treat overdoses, and other significant new resources focused on addiction. It certainly stands as recognition that addiction is seen as a multifaceted problem that increasingly is receiving treatment and not simply a punitive approach, as we saw in the late 1980s and continuing. So that's one significant development. Just to move back, even though I started off the presentation by saying that the whole point of this presentation was to look beyond the Mental Health Parity Act and the Affordable Care Act, it is significant to note that they are major historical developments. They aren't the point of this program today is that they aren't the only things that we should be looking at, but there's without doubt mental health parity is very significant. We are seeing guidance coming out from the Department of Labor and other federal agencies on what is out of bounds for health plans in terms of how they treat the benefits and coverage requirements that are imposed upon addiction treatment and mental health relative to medical surgical benefits. We're going to be doing significant programs, and a specific program dedicated to clarifying some of the standards and the rights of both patients and treatment programs with respect to abuses and discrimination. It's a major problem, but mental health parity, we're now 8 years after its enactment, we're only now beginning to see some significant movement in understanding what the limitations on health plans are, and we have not yet seen significant enforcement action. So as is always the case with new laws, it takes time for an understanding of the laws to be developed, for regulations and guidance to be issued by government agencies, and for enforcement to happen. And so one thing that I think we're going to see in the next decade is a significant rollout of enforcement careful review of mental health parity, and so that it is a significant part of the landscape. The Affordable Care Act obviously deserves enormous credit for the inclusion of a mental health and substance use disorder benefit as one of the 10 minimum essential elements of coverage. This really was a significant elevation of mental health and substance use treatment by mandating its inclusion in coverage, both for plans purchased by individuals on the health insurance exchanges and for employer-based plans. So these laws do deserve credit for some of the significant changes that we've seen. So we are now in an environment, I wanted to turn a little bit about to this moment in time. I would submit that if you look at the history of the last 150 years, you see a growing awakening of awareness of addiction as a public health crisis, and a growing awareness that it's an undertreated crisis. Some of the numbers that we have from SAMHSA are 46 million Americans today with a mental health disorder, 24 million Americans with alcohol or drug disorders. I know that there are people who use even higher numbers in the addiction treatment community from other sources. 60 to 80 million Americans at risk of an alcohol or drug problem. So we are at a point where awareness of the problem is really has really reached a critical mass. I think you can make a compelling case that the Mental Health Parity Act, the Affordable Care Act, Cara, are all a reflection of at least an understanding that the problem is undertreated. The question, of course, for the addiction treatment program community is how do we get to expanded resources, and what are they going to look like as we see an expansion to treat the need and ensure access. So I wanted to just give a few general thoughts and then talk about some of the changes in a little more detail. So some takeaways from the historical review are this evolving awareness of addiction as a public health crisis and as a medical rather than a moral condition. That is really one of the positive takeaways for anybody who works in addiction or is part of the addiction treatment community. We have seen significant progress on this front. One of the things that we haven't talked about much in this program, but sort of comes out from some of the historical detail, is that we are still in the midst of an ongoing struggle to understand and develop an effective treatment model. And we're going to talk a little bit about that in the program, but I think it comes out in several ways. It comes out from some of the lack of evidence-based treatments. For example, the treatment of the fact that Sigmund Freud was in the late 19th century offering cocaine as a treatment for heroin addiction is emblematic of an approach of how even one of the giants of psychiatry was really at a loss for how to treat addiction. And I think that we see an ongoing struggle to understand and develop an effective treatment model, and I believe that we will see in the coming decades we're going to see significant advances in what the effective treatment model is. There is not great research today on any of the treatment modalities that are out there. We're going to talk more about that in future webinars, but that is something that both presents opportunity for those who can demonstrate efficacy, but it's also a challenge for existing programs. And I believe that all addiction treatment programs should be evaluating their outcomes and should be paying close attention to evidence-based approaches in understanding and developing effective treatment models, and that ultimately the road to success is going to go through efficacy and quality of care. Another theme that comes out of the historical review, I believe, is that access to care has always been differentiated. When I say always, going back to the 19th century, throughout the modern history, there has been a differentiation between high-end resources that are cash pay for those who have resources, and very low-end publicly funded resources for the poor. And I think that this is still a challenge to create affordable access to care for the great middle, is an enormous problem, and I think that that's a challenge that still is going to need attention ahead. But it's interesting to note that this is not a phenomenon of the last few decades. This is really an old problem. Competing ideas of whether the treatment should be led by clinicians as opposed to led by veterans of the recovery community. This is really a concept that we still see very much alive, and I'm not going to address it in great detail, but I think it's interesting just to note that this is a point of tension that has been around for decades and remains as to what effective treatment is, particularly as we talk about social model and its efficacy. Insurance reimbursement, I think one of the underscoring historical lessons is that the availability and then the cutbacks and retrenchment on insurance coverage availability has been a driver of growth of different services in a treatment setting. We saw that the inpatient treatments grew and then shrank as a result of the unavailability of insurance coverage, and pushing things into an outpatient setting, and pushing the need for unlicensed sober living housing. And I think that we're going to see this as an important feature ahead, and also an important battleground in the wars over what mental health parity means in terms of the right to residential treatment, assuming that that efficacy is established for residential treatment in the future. Finally, the last major takeaway that I want to leave people with is the extent to which the regulatory categories have emerged in earlier eras and in a very siloed way. And we're going to talk more about that on our next webinar dealing with the various regulatory categories. But it's interesting to note that the categories continue to change. We are only 3 years into the Department of Healthcare Services in California being the regulatory agency that licenses addiction treatment programs in this state. And it is interesting to note that the recency of this change leads us to anticipate significant changes ahead in California. And as a separate point, it's interesting to note that the recency of means that there is a much higher degree of variation state to state in agencies and regulation than compared to other healthcare services. If you look at what care looks like in a hospital in California and a hospital in Oklahoma, you will find very much more similarity than you will if you compare a addiction treatment program in California and an addiction treatment program in Oklahoma. So it's interesting to note that as you go from state to state, there's significant variation in how addiction treatment programs are regulated on every level. It means that we're going to need to do significant work ahead as a country to create more uniformity around best practices in regulation. And it also means that for programs that are operating in multiple states, there is a need to be very careful about respecting the differences in the regulatory approach from state to state. I wanted to just leave with some overview top-line points that I hope come out of the presentation today. First, we've seen an evolving understanding of where addiction treatment and substance use disorders fit in the broader healthcare context. This is related. Addiction is a related but distinct category from mental health, which mental health is a focus on a person's condition with regard to their psychological and emotional well-being. And we've seen a shift from mental health to behavioral health. Behavioral health being all human behavior that's actionable, not merely promoting psychological and emotional well-being, but also preventing or intervening in addictive disorders and in a broader range of behavioral issues. So that's a significant change in the context of where addiction treatment fits into the broader healthcare and behavioral health context. We're seeing an evolving treatment model, and I think it's unmistakable that we are in a period of transition from a predominant form of social model treatment to a medically driven model. That we're still very much in some parts of the country, including in California and Florida, seeing a predominance of social model. But I do believe that this is a change underway, and that this is a challenge for social model programs to adapt to an environment in which evidence-based approaches the role of medical intervention, both from an efficacy standpoint and quality of care standpoint, and also from a cost standpoint, are intervening and changing the way that addiction is treated in this country. Some of the shift to evidence-based practices, I wanted to just articulate what we're talking about. We're talking about best research, best practices evidence that supports clinical approaches. We're talking about clinician expertise and using clinical skills and past experience to treat individual patients. And we're also seeing a growing move towards patient values, so the integration of patient preferences, concerns, and expectations into addiction treatment. We're seeing that treatment in addiction is really moving towards a more comprehensive view, that it's no longer just a matter of having a residential or outpatient-based care, but really a process that involves a lot of supportive services around it. In some cases, these may be services like housing and transportation, vocational services, educational services, financial services, legal services, for all of the issues that have arisen around the addiction. Addiction treatment, in distinction from classic medical conditions, will often involve many of these other aspects. We're seeing that there's a need for many distinct parts of treatment, and really an evolving view towards a much more comprehensive set of services in addiction treatment. In a fascinating challenge that we're going to have to cover more in the future, and we don't have time for in this presentation, is the extent to which some of these services are covered by insurance and others are not, and how those services get provided and funded is going to be an enormous challenge ahead for the industry. We're seeing a significant evolution in the reimbursement model. Historically, as we noted, we had a system of the extremes of cash pay programs for the affluent and Medicaid funding for the poor, and now we're in a period where there's an insurance benefit, which the Affordable Care Act and Parity Act prohibit discrimination. So offering reimbursement for a much broader group of Americans, and that's going to be continuing to evolve, and is really going to be something to watch in the decade ahead. And finally, we're seeing an evolving regulatory system. We're seeing the move from siloed drug and alcohol licensing to a more integrated relationship with other kinds of facilities. And while in California, there still remains a silo in the sense that the Department of Healthcare Services is only regulating drug and alcohol, whereas other agencies are regulating healthcare and residential care facilities, I believe that we're going to be seeing more integrated licensing and certification relationships in the future. So I hope that this webinar has been interesting in giving a policy level overview of some of the historical developments and some of the changes that are underway. As always, if you'd like to discuss or have questions, please feel free to reach out, and thank you so much for listening today.